So my name is Andrew Storr. I'm the Chief Nursing Officer here at Roswell Park Comprehensive Cancer Center in Buffalo, New York. And I'm really excited to be going to NCCN this year. Ambulatory care makes up about 80% of all oncology care delivered today, and more of care is being shifted from the inpatient setting to the ambulatory space. And folks are living longer. They have more comorbidities, like more diabetes, congestive heart failure, and other medical problems. And then with the cancer number of cancer cases increasing and folks becoming sicker, they're much more complex than they were 20 years ago. And on top of that, cancer care is becoming much more complex as well. The cancer is now considered more than 100 different diseases. Artificial intelligence use in diagnosis and treatment, immunotherapy, looking at the social determinants of health and barriers to care as patients come with all that into the ambulatory space. And historically, we have had very much a transactional model of care in nursing, whereas patients come in, they receive care, and then they go about their day, time to the next visit and follow up, and whatnot. What's happening, though, is that there was some research in the early 1990s on patient navigation, and it looked that if you take a patient and remove barriers to care, transportation issues, help people with their insurance, ensuring that the CAT scan that they need in 2 weeks is booked and appropriately done so, and that the labs you need beforehand are done so that these things can kind of go in a systemic way. When you remove barriers to care, and those barriers can be financial, communication, medical system, fear, distrust, complex home situations. The navigation research showed that the 5-year survival went from 39 to 70%. So significant finding, and that was back in the early 1990s. Move forward today, and patient navigation has kind of become an increasing point in the literature. But now we've moved to a point where we also need care coordination because the patients are coming in at an older age with more complexities, with more complicated treatment therapy and options. And so wrapping an oncology nurse coordinator, which is our model that we're implementing here at Roswell Park, is kind of a model that ensures that what we do is, number one, patient-centered. We answer every question with, how does this benefit the patient? But ensuring that we are the one resource for that patient, that nurse is that patient always has that nurse to reach out to assist with their care and to help ensure that the follow-up, to assess treatment side effects, to assess their frailty, to assess any barriers that they may have to be, with receiving care. And then ensure that after the care they receive, in between those touch points, that we're able to communicate with the patient and assess early for things like toxicities of immunotherapy so that we can get in front of them earlier rather than the patient coming, presenting for a sick visit, 2 weeks later. So the first thing we did is we're standardizing our staffing models. And so we're working with each clinical team to wrap, an oncology nurse coordinator, a nurse practitioner, a physician assistant, and then a physician, so that we have a clinical care team around that patient. Now we're also embedding, clinical trials navigation, social work and support around the patient as well. And so what we're doing is going to each clinic and saying, what does your panel of patients look like? Who are your panel of patients that are on active therapy versus those that are just continuing and need an episodic, visit once or twice a year? Who actually needs care coordination? And what does that look like in terms of volume? Is one nurse coordinator enough for or do you need two? If you're, have 400 patients on active therapy, then perhaps, you may need two nurse coordinators to work in your team, each would have their own panel of patients. So we're really engaging the local leaders and the local frontline clinicians and what those teams look like to ensure that we have what works for them. I mean, we want to obviously implement a standardized model so that we can measure and evaluate the care that we provide and demonstrate impact, but we also want it to be very personalized and engage those frontline stakeholders to, improve ownership. I think that now is a pivotal time as healthcare is becoming more efficient and looking to streamline and decrease cost overall in healthcare. And many teams have saw that as decreasing the professional nursing in the ambulatory space. But in my opinion, and I think we have some initial data to support this, embedding a registered nurse into the care team in the ambulatory space is going to improve care, improve adherence, improve, treatment rates, and, help keep the patient in the ambulatory space more successful, decreasing admissions and whatnot. And so it's a time to kind of permanently embed nursing into the ambulatory space. A few of the lessons we've kind of learned is doing this. Number one, we always ask, is this the best thing for the patient? And we've learned that collaborative relations supersede evidence in many ways, right? We need to work with our frontline teams to ensure that they are 100% patient focused, but I don't know, in our teams don't know, that patient population as well as they do. They're the local experts. And that, culture change like this really requires patience, persistence, and time. Project management's really key, and that we need to really prioritize sustainability and employee resilience because healthcare is not getting any easier, and we want to make sure that our workforce is taken care of. It certainly takes a team, and there's definitely space for everyone. Registered nurses, licensed practical nurses, medical assistants, and clerical staff. It takes everyone to make sure that the work is able to happen and to coordinate that care around the patient. One of the things I think we've learned is that there's disease site knowledge that the nurse coordinator and the clinical team needs to know, but there's also a whole list of other competencies required for care collaboration, whether, that's using an evidence-based method of patient education, such as the teach-back method, providing interventions at certain time points along the patient's journey to decrease readmission. So there's that whole kind of care coordination competencies, which we are developing and implementing and providing real-time education on, as well as the disease site stuff that folks need to know about, leukemia or lung cancer or whatnot. This is just, data that we're beginning to look at, and what are the measurements we actually want to agree on? Is it time to treatment? We don't have standardized metrics in care coordination that, bodies have agreed on. And so I think it's important, and I'm going to be discussing this at the NCCN conference, is that we come up with some standardized guidelines. Is it barriers to care remove? Is it time to treatment? Is it time toxicity, meaning the amount of time a patient spends receiving care, because that impedes their quality of life? Is it health-related quality of life, social needs? And so I think we're at a prime opportunity that probably has a big impact on care. I mean, we know alone that social determinants of health affect about 80% of outcomes. But if we provide care coordination in that, and how can we help improve those?